respected seniors and dear friends, warm good evening to one and all. Before I begin, I wish to express my sincere thanks to Mithun Armugam sir and the entire team from Chennai Arthroplasty Forum for giving me this opportunity. So today I'll present a case which is a case of multiple joint replacement in the case of rheumatoid arthritis and what are all the complications I encountered and how I managed it. So the history starts from July of 2023. It was a 60-year-old female who had presented to me with complaints of pain in the left hip and both knees for 4 years duration. The rheumatoid arthritis was diagnosed way back in 2008, involving both hips and knees, for which she was on methotrexate, HCQS, and appropriate analgesics. She also had severe osteoporosis, for which she took injection terifrac therapy for 1 year in 2014. She also had fractured neck of femur right side, for which THR was done in 2016. And following this, while doing physiotherapy for knee stiffness, she had fracture. This is what the patient claims. There was no injury, it seems. While doing physiotherapy, she had fracture of both bones, right leg, for which ORIF was done in Jan 18 and implant exit done in July 2018. Along with it, other comorbidities, she had interstitial lung disease and a history of old CVA. For the past 6 months, she is totally wheelchair bound. She is not able to move around. With regards to clinical findings, classical findings of arthritis in the hip, tenderness over the anterior aspect, there is proximal migration of the trochanter, a fixed flexion deformity of 10 degree. Further flexion was only possible up to 30. There was a fixed adduction and internal rotation deformity, an apparent shortening of 4 and a true shortening of 1.5. With regards to the knee, both knees had a fixed flexion deformity of 30 degrees, valgus alignment on both sides. Range of movement was from, sorry, not 20, it's 30 to 120 degrees. And the right ankle had a healed scar over the distal third aspect. There was no neurovascular deficit. And this is the X-ray of this patient. We can see protrusio here and the proximally migrated trochanter with the erosion of the head. And this is the CT, which showed that the medial wall of the acetabulum was still intact. And based on the Sotelo-Garza classification, it can be classified as grade 3, where there is more than 15 mm of medial migration and the center edge angle of 115 degrees. And with regards to pre-op planning, I would request the forum members to kindly give me some inputs on, for this case, what would be your rationale for exposure, what implants would be your choice, and other inputs on these parameters, need for augments, solution for protrusio, any soft tissue releases planned, and precautions and limit discrepancy. So if I have some inputs,
So, I mean, yeah, Cheralathan,
shall I go to the X-ray?
So only the, I mean, you are planning.
Cheryl, CT or lateral view?
This is the CT, sir. I'll play it,
Okay.
sir.
How is the medial wall?
Medial wall is intact, sir. You can see here, sir.
Then it will be a straightforward THR, no?
Okay, sir. So fine. So I'll
Yeah, I think
proceed.
generally, I mean, the static now we are allowed to expose.
Yeah.
I mean, it might be a little bit close to the exposure in this case.
Exactly.
Other than that, I don't see a need for augments. You'll be able to use the femoral head as a graft, and because it's mostly a superomedial defect, rim is still intact.
Yeah.
So I think you should be able to get away with just a medial morcellase bone grafting.
Thank you. Thanks for the inputs, Arun and Mohan, sir. So I'll proceed with my case. So like discussed, I used a posterior approach here. I couldn't dislocate the head, so I did an in situ osteotomy. Femoral head was used as bone graft, impaction bone grafting was done. And rim fit porous coated stem was used, top size 50 mm, head diameter 32. I used a cemented stem here. And intraoperatively, there was a GT fracture. And unfortunately, I didn't have a stem centralizer that day. So you can see that the stem tip is in a valgus. And with this, my post-op protocol was to plan for mobilization from the next day, since I had fixed the GT and there was a soft tissue sleeve continuity there. So the patient was doing well post-operatively. And in the post-op room, about 4 hours after surgery, there was a sudden onset of chest discomfort, giddiness, the BP was dropping, heart rate rising, SpO2 was 96. I was really very worried. And the cardiologist was called for, and they examined all parameters and declared that this is a case of stress cardiomyopathy. Until then time, I didn't know that there was an entity like this. And once I Googled it up, it showed these features. And it is a temporary condition that causes the heart muscle to weaken. And the last line was a bit scary. You can see here, stress cardiomyopathy is a reversible condition, but it can be life-threatening. I was really worried for this, but luckily the patient recovered within 24 hours. So I thought with this complication, I could go away. So starting from day 2, patient was made to walk using a walker support. I reinitiated the teriparatide therapy to take care of her weakened bones, and she continued her rheumatoid medications. And this is at 3 months post THR. She is able to walk, but because of the knee valgus and flexion deformity, she's difficult to she's finding it difficult to walk again. She's continuing treatment for osteoporosis and rheumatoid. And with regards to her knee flexion, I had advised stretching exercises just to reduce the amount of flexion contracture. To begin with, you can see it was around 32 degrees, which gradually reduced to 23 degrees. And the flexion was very good. It was almost 130 degrees. And that is the Q angle, which is about 20 degrees on the right side. And the X-ray, here we can see there is an evidence of a stress fracture, which is probably healing as well. So, and this is the mechanical axis of the entire limb. You can see there is a gross valgus, and the hip KA axis is 23 degrees of valgus. And the stress test showed that the MCL is still, MCL integrity was confirmed. And here we can see there is metaphyseal remodeling both on the femoral side and in the tibial side. This is the evidence of the previous fracture in the distal tibia. So with this, again, can I have some inputs from the forum members? What would be the exposure for this case? Implant options, augments?
Yeah, I think that is probably not a stress fracture because it is on the, on the wrong side of the deformity. If you have a varus, then you can expect a stress fracture to start on the medial side, stress reaction. But this looks more like a loser zone kind of picture. So, I think that's probably not a stress fracture.
It's not stress fracture. Okay,
It's on
because
the,
since
it's on the wrong side. Yeah, it's
okay,
thickening on the wrong side of the deformity. Yeah.
okay.
So, yeah, but yeah, I think it's a fairly standard rheumatoid valgus knee with a lot of osteoporosis, like what you had seen on the hip side. So, I think I would have definitely a stem backed up. If you're comfortable with the
CT is taken.
skyline view also for these.
CT for the knee, I didn't do, sir. CT was done only for the hip, sir.
It's more of like bone thickening, maybe osteoma also can be there.
Okay, okay, sir, okay. Possible.
Any skyline view available?
Yeah, I couldn't do the skyline view because the patient was not comfortable with that position and she didn't cooperate for it. So for this case, I didn't do the skyline view.
You can see the patellar tracking. Some of these valgus knees, they have horrible patellar tracking. You can see that. Other than that, okay. If
Yeah.
you can manage without a skyline view. Yeah,
Okay.
I think
Yes.
valgus knees also, valgus stress view would be helpful.
Would be helpful. Yeah.
Yeah, because
And this
you
is
might
the standing view. So this is the
Yeah.
standing view. So I think this will compensate for the valgus stress. You can see that there is almost about, I think, not much of an opening on the medial side. There are osteophytes on the lateral side.
Yeah.
So
standing view is something standard we all get. Just in this is, rheumatoid, they generally don't have that much MCL laxity, but generally for valgus knees, apart from the standing X-ray, we should get a valgus stress view just so that you might be prepared with a varus valgus implant or sometimes a hinge if it is too much. That is the only thing.
Definitely.
And that in these cases, I think standard implants with plus or minus stem would probably be needed on the tibial side for these cases.
Side.
Yeah.
Yes. Thanks a lot. Thanks a lot. So I'll proceed from here. So like sir?
I have a doubt, sir. I'm Dr.
Yes, sir.
Sir.
Yes, sir.
Usually we
Sir, sorry, I'm not able to.
Routine valgus knee. Do we really need to take in skyline view in case of valgus knee, sir?
Yeah, it will help with with the patellar tracking, sometimes valgus
Sir,
knees have more patellar maltracking.
valgus knee, most of the cases.
Yes, yes.
Okay. Sorry, I didn't get that question, and I think Arun had answered it. So I'll proceed with the presentation. So like the points given here, and I was a bit worried since there was a flexion and a valgus deformity. I gave a caution to the, sorry. Okay, I gave a caution to the patient attenders that there is a risk of common peroneal injury here.
Mostly
I think your connection is quite weak. We are not able to hear you. Cheralathan, you can proceed.
Yeah, sure. Okay. So I had given a word of caution to the patient as well as the attenders. And yeah. So this is the post-op X-ray. I had used a lateral parapatellar arthrotomy here. I had used a 3-degree distal femur cut. And since there was tightness in the extension, I couldn't bring the knee into full extension. So I took an additional 2 mm distal femur cut. So I went for 11 mm distal femur cut and a 9 mm proximal tibial cut. Even with this, there was lateral tightness. So posterior capsular release, a posterolateral release was also needed. And finally, IT band release clearly gave me a rectangular flexion, extension gap. And the component sizes were 4 PS femur, a size 2 tibial plate, and I had used 150 mm cross 14 mm size tibial rod, like the point, Arun had suggested. And the liner was a constrained liner. Since I had used stem, and there is a risk of osteoporosis as well here. So I went for a constrained liner here. So any comments about the X-ray?
Looks really good. Yeah, I think.
Thank you.
So why
Thank you.
constrained liner,
Sir, I had added a stem here, sir. So I felt a 9 mm regular or 11 mm
Okay.
regular thing was a bit loose on the medial side, sir. So I thought going for the thicker post one, sir, that liner. So I thought that would give you a better
okay.
stability and the patient could tolerate it. Yes.
PS.
Yeah, PS. Yeah.
Because
And
if you're
so
constrained liner, the movement's flexion will be restricted, no?
yeah, this yes, sir. Not the completely constrained, sir. The one with the thicker post alone, the center one.
Okay.
Yeah, Cheralathan, 2 points. I think, see, because if you are using a constrained insert, then there is a logic in adding a stem. But
Okay.
it doesn't mean the reverse. If you are using a stem, it doesn't mean we have to go for a higher constraint. I don't know if you meant that, but I think that's not the case. If you are using a
I
constraint
agree.
insert, then you have to use a stem. That gives some
Stem, yes,
protection
yes.
because you are using a constraint. But the reverse is not true. If you use a stem, it doesn't mean that you go up on the constraint.
Yeah.
I think here
What
most of the
Arun says is
cases
correct,
will have
actually.
some medial laxity. For those cases, I think it is difficult to balance. So those cases you can use a varus valgus constraint if you are not
Constraints.
getting a perfectly rectangular gap.
Yeah. Yes, yeah.
And sometimes in
you have put it the
FFD,
right way.
the
Yes.
friction laxity might be higher. So those cases also are helped with the varus valgus constraint insert, but it
Constraint.
doesn't affect the flexion in general. It almost functions like PS in flexion.
Flexion.
I mean,
Yes.
as far as rollback is concerned.
Yeah. Since I had planned for the stem even in the preoperative period, I think I had put it in the wrong way, but you had rightly corrected me. Point taken. So the patient was happy.
The X-ray looks very well.
Thank you, sir. But there was a big surprise in the post-op, sir. I went for the evening rounds and it was foot drop. The patient had no sensation over the dorsum of foot and total loss of foot and ankle dorsiflexion. And that is how I was sitting in my consultation room that evening. But luckily, since I had got a consent explaining this, I thought, okay, the patient might understand. But right then, I went for searching some textbooks and literature, and I was literally lost in what to do starting from now. So I searched for evidence and what are the medications to give. I had contemplated using foot drop splint. What mobilization should I do? And one thing I did was I immediately kept the knee in flexion so that to release the tension on the peroneal nerve and wait and watch. That was all I could do. With regards to medications, I had started on pregabalin and I had given dexamethasone for steroid to reduce the inflammation in that area. And luckily, in the second post-operative day, the patient showed some improvement. I really don't know how it worked, but still, it was total luck. So the patient could dorsiflex ankle and toes, and power was almost 3/5. So, and that is when I gave a sigh of relief. And at 1 month post-op, there was complete peroneal nerve recovery. Sorry.
Did you use
And
tourniquet?
I used tourniquet, sir.
Because of that, it would have been there.
Okay, okay. Sir, is
That
it a
compression would have
risk
been.
factor to use tourniquet in such cases, sir? Because I was not aware of that previously.
Oh, depends on tourniquet duration.
Duration. The duration was well under 90 minutes. Yeah. The
Then
total,
I think, yeah, effective tourniquet.
yeah, it was well under
Maybe
90
the
minutes.
pressure would have been more, so that the compression would have been more there, actually.
Yeah, sir. But what I thought was
But
maybe
that
I acutely corrected the deformity. Maybe I should have done it a bit more gradually. Maybe I was not able to know the exact etiology, but to be honest, I think I got lucky here. That's what that's what I should say.
Sir, but
So
in,
at
fixed valgus deformity, better to keep the knee in flexion in post-op during post-op.
post-op period, yes, yes,
In fixed
rightly said.
valgus deformities.
Yeah, rightly said, rightly said. So I think that alone helped me because I noticed it. I noticed this complication in the evening post-op round, so I immediately kept the knee in flexion. So continuing with the case, at the end of 1 month, the nerve recovery was complete. The incision site had healed well. The range of movement 0 to 100 without any pain, and she was able to do full weight bearing walking. The patient was happy, and now she wanted the left knee to be operated again. So we moved on. So that is the flexion on that side, 22 degrees flexion deformity, and the valgus angle here is 16 degrees, and a fairly good range of flexion available. And this is the X-ray, a very similar X-ray, except that there is no medial cortical thickening like the one seen on the right side. And the distal, and here again, the HK axis is about 11-degree valgus. And here also we can appreciate the metaphyseal remodeling both in the femur and in the tibia as well. So the same plan as the previous knee. And and in this case, I didn't need a stem, and it was straightforward knee, but a straightforward primary knee. And here again, I used a lateral arthrotomy, and the components were size 4 and femur, PS femur, size 2 tray, and a 9 mm poly liner. So any comments about this knee? I'm sorry for the lateral view; it was taken this way, so I couldn't get a better lateral view. So any comments, sir?
One comment I would think is, I think lateralize the tibia, like,
Tibial.
especially rheumatoids, osteoporotics, if you leave it uncovered on the medial side, these people are at a slightly higher risk of varus collapse of the tibia.
Varus collapse.
So I
Okay,
think,
okay.
tibia looks a little bit undersized to me. I mean, if you had added a stem like what you had done on the other side, it is perfectly okay. But without a stem,
Okay.
I'm not saying every case will collapse, but
Okay.
if you do maybe 100 cases, there is a higher risk of tibial collapse if it is there is no cortical support on the medial side.
Medial side. Yeah. Point taken. Point taken. So I totally agree. So it would have been better to add a stem here as well, in this knee as well. Yeah, okay.
Yeah, I think
So
so.
sure.
And another small
So
point I had to make
yeah,
then. So on the left side, on the right side, you said you had flexed the knee. So generally, when you flex the knee, it also flexes the hip, and they say, it is only a theory. When you flex the knee and flex the hip, sciatic nerve gets stretched at the hip and relaxed at the knee.
okay.
So there is no proof for what I'm saying, but I've heard a lot of people in
So
AIMS.
the compression could have been right up in the proximal part of the nerve.
No. After the foot drop happened, when you put
Okay.
you flex the knee, right, to relax the sciatic nerve.
Yeah.
So what we were taught in AIMS was, I don't know, there is no 100% proof backing for this, but you bring the patient towards the edge of the table, flex the knee, so that
Okay.
the hip remains extended, but the knee
Extended.
flexes.
Okay.
So you bring the patient to the edge so that the knee is just, let's say, resting at the end of the table, and only the knee
Okay.
gets flexed. The hip doesn't get
Great.
flexed, so that will avoid stretching on the
Stretching
sciatic nerve.
the. Great point. I couldn't think of at that time. For that particular case, I maintained the knee in about the pre-surgery flexion, about 20-30 degree flexion using posterior support at the knee level. I think, but the hip must have been in flexion only, maybe another 20-30 degrees. So point
Yeah,
taken.
it was more there.
Yeah. So I'll go ahead. So the patient post-op day 1 vitals were stable. Patient was made to stand. She was very happy to see both her legs straight, and both surgeon and patient was happy. But the story didn't go that way. POD2, when I opened the dressing, there were multiple blisters. I was really shocked to see that. Multiple large blisters and at least 3 blisters of size 5 cross 5 centimeters. I don't know what went wrong there because she had thin skin, but this is the first time I encountered such a problem. So any inputs on this? What could have gone wrong here?
Blisters might be due to edema of the skin, sir. It can occur, and
Yeah, I think
Do you have a picture of
No, so
the?
that's very sorry, sir. I didn't have a clinical picture taken at that time. I was in a state of shock that I really
These
didn't take a
blisters on
picture.
the blisters on the medial side of the incision or the lateral side?
Lateral side, sir. I will show you the clinical picture right now, the heel blisters, we can even see. So I really got scared this time. And
But this
what I
time,
did was sir?
yeah, you said earlier on the other side. I thought I heard you say that you went by a lateral parapatellar approach.
Exactly, sir.
And this one also
Both,
lateral
sir.
parapet.
Lateral parapatellar. Yes, sir.
I wonder if that has something to do with it. Anyway,
Maybe, sir.
let's see.
Okay, sir. So
Sure.
how I managed it? I just give a thorough paint of the leg, and in a sterile manner, I drained the fluid. I didn't denude the blisters, and I left it to collapse. I maintained the limb elevation, gave anti-edema medications, chimeral fort. Ice pack fomentation was applied. I postponed the mobilization. I just kept the patient under rest, and here also I maintained the knee in a bit flexion, a 15-degree flexion. And I had to counsel them, suppose if the skin goes in for necrosis. Unfortunately, I had discussed with plastic surgeons as well and explained this to patient as well. But luckily, in POD5, the patient said that pain has reduced now. The edema is also reducing, and there was no fresh blisters, and the already existing one showing some signs of wrinkling. And now I initiated pain-tolerated gentle knee bending alone, not to the full extent. And I delayed suture removal, which was removed only on the 21st day. By the time skin had healed well and patient could bend up to 90 degrees, there was no pain. But now we had a problem of extensor lag. And I could passively extend it up to 10, but not complete extension. So this is how the patient was able to stand. And I heard about this physiotherapy method, instrument-assisted soft tissue mobilization. I had discussed with the hospital physiotherapist, and he suggested that this will help for muscle tightness, and it really helped. So almost by 4 to 6 weeks, the patient was able to come to this position. Starting from here, she was able to reach this position. And then walking training with a single stick. You can see the blisters on that side, sir. I'll play the image here. Here, this is where the blisters were there. And the latest follow-up was 18 months post THR, 11 months post right knee, and 10 months post left knee. This is the latest X-ray. The graft had incorporated well. The shell stayed in place, and the trochanteric fracture also found to be united. And the right knee, the left knee, the recent X-ray, and the clinical appearance of the knee now. And now she is able to walk comfortably without support, but she has a waddling gait, which I assume should be due to her sarcopenia because of the long duration rheumatoid. I'll play the video again. She has waddling. She lurches on both sides. And from a patient who presented with stretcher, now she's able to go around her community, go to church, and she feels really happy now. Sir, can I have any inputs on what could be the reason for this lurch, sir? Is it only because of the muscle weakness or could be something else? But she has no pain. There is no pain.
I think patients who haven't walked for such a long time, they really require some gait training because there's a whole lot of other soft tissue secondary issues with respect to not being in bed or
Yes,
being chair bound. I mean, even patients I've seen who were walking and then they sort of delay a replacement because they're basically just scared. They take much longer to bounce back.
longer too.
Same thing with rheumatoids also. So it's possible that it might improve.
Might improve. Okay, sir. I'll keep the patient in follow-up. Maybe after a year or two, I'll present this case again with the updated results.
Yeah, but otherwise it looks good. I mean, everything's
Thank
turned
you,
out
sir.
well.
Thank you, sir. Thank you. I really got lucky with, I was able to get away with all the complications I faced in this case.
Yeah, but
Thank you for the
the
patient listening.
lateral parapatellar thing,
Yes, sir.
that's because of the valgus, is it?
Yes, sir, because of the valgus. I have seen my
How much of
mentor,
the-
Singarodivulu sir, do it. So
Yeah.
I thought, okay, I could do the same in these cases. I tried to,
Yeah, but
I
not
tried to
a-
copy him.
It's not a Keblish.
Yes, sir.
It's
Sir,
not
sir, I didn't
Keblish.
get you.
Is it a Keblish lateral